Dr. Dani Cabral here, founder of BrainLove. Today we're going to talk about memory loss and aging, when and how to talk to your healthcare provider. So the topics we're going to cover: what are features of memory loss and thinking changes in normal brain aging compared to dementia, such as Alzheimer's disease? What are warning signs that it is time or maybe overdue to talk to your healthcare provider? And what are real action steps you and your family members can take to get your healthcare provider to take your memory loss seriously? We all experience changes in our thinking throughout life, though it's clear that some of these things do increase as we age, and this can be very concerning for us. Some of the common thinking complaints in aging include short-term memory issues, slowness in thinking, trouble sustaining attention, trouble keeping your focus. Multitasking becomes challenging sometimes. Keeping information in mind and then switching to something else and then going back to that information or task can be challenging. And there's often word finding difficulties. This can happen at any point in our lives, and there are so many possible reasons this could happen. That can include things like stress and anxiety. That is a huge one for us these days. When we are experiencing short-term or chronic stress, our smart thinking brain goes offline, essentially. So that's the prefrontal cortex. And then we're moving into more of that emotional, survival-based part of the brain. And then, of course, it can become harder to think, problem solve. Having depression or anxiety can impact our thinking. Another big one that a lot of us are facing is sleep loss or insomnia. When you have a bad night's sleep, it's common to feel slowness of thinking, brain fog, also medication side effects, hormonal changes, chronic illness and medical conditions. That's certainly something that we see commonly in older adults. And every one of these piled on top of each other in an older adult whose brain doesn't have those compensatory strategies like we once did when we were younger, can experience a variety of changes in thinking. Other things that can impact this: alcohol or other substance use, emotional trauma or PTSD, lack of mental stimulation, social isolation, loneliness. COVID has been a time that we have learned a lot about the impacts of loneliness, particularly in older adults, and especially for those who have dementia, who are severely isolated. We did see that those individuals who had dementia, who were quarantined, who couldn't see their family members, in general, they had a worse course and their lives were shortened more than we would have expected if COVID wasn't going on. Poor nutrition and dehydration is a big one. This is a theoretically simple one for us to pay attention to and to address. However, as we get older, our sense of hunger and our sense of thirst decreases, even though we still need the nutrition and the hydration. I'm in Phoenix, so it gets very hot. It gets in the 120s sometimes during the summer. And we have older adults that may not notice and realize that they really do need water. And it is not uncommon for individuals to end up in the hospital because they're so dehydrated, their blood pressure drops, and that can lead into a whole host of detrimental effects. So that is something we need to pay attention to and address. And then cultural and psychological factors can play an impact on changes in thinking. And this one is more maybe from a perception perspective. We feel like we're not thinking as well, and it's especially for people who are high achievers. Their identity maybe is about how smart they are, what quick thinker they are. So as they're aging and these normal brain aging factors are happening, or maybe pathologic changes in their thinking from something like Alzheimer's disease starting up, those people may notice more and have more anxiety about it, and that anxiety is a self-perpetuating cycle, and that can lead to worsening of thinking. I'm going to focus on specifically normal brain aging. There are things that happen to all of our brains as we age. It's essentially starting to break down. And this happens in our bodies too. So what's happening? The neurons or the brain cells, there's changes in these. And they're not going to essentially be able to pass the information between the neurons through the synapses as efficiently. And so this can affect our thinking in a whole variety of ways. We have changes in our brain plasticity or neuroplasticity. Now, this is a hot topic. People love to talk about neuroplasticity. These are the brain's ability to create neural connections. And as we age, ability to reorganize or form new neural connections declines, and that leads to reduced flexibility, which can make it harder to learn new information or adapt to changes. Now, having higher education is one protective factor against developing dementia. And this is likely because one who is more educated tends to develop more neural connections. In other words, increase brain plasticity or neuroplasticity. When that person starts aging, they have more networks to fall back on if some of them start to become faulty. There's also changes in brain structure. This can happen in a variety of places in the brain and can affect cognitive functions as well. And I'll give one example that is common, which is that the optic nerve, which is going from the eye to the brain to communicate visual input, can start to degenerate. What that means is that, for example, the message of the sunshine coming into the eye to tell us that it's daytime, it's time to get up, it's time to turn off the melatonin, it's time to get up from our sleep. That message is not getting transmitted as efficiently and as quickly. And so what that could do is disrupt that sleep-wake cycle, the circadian rhythm, which can contribute to sleep dysfunction. Other brain changes that happen in aging are vascular or blood flow changes. The blood flow can be diminished with age, which can impact the delivery of oxygen and nutrients. And then finally, other changes with brain aging include cellular damage accumulation. So over the years, from a variety of oxidative damage and cellular stress, this can damage the brain cells, which can contribute to gradual cognitive slowing. Now, I don't want to sound like aging is all bad and our brains, all of us are going to have cognitive decline, because that is absolutely not the case. And we know lots of older adults who are perfectly cognitively intact. There are individuals who with aging are able to maintain their cognition. They appear to have cognitive resilience. Luckily, there's a growing number of researchers who are looking into what are the factors that contribute to cognitive resilience and resilience in aging in general. Some people genetically are a little bit luckier with this, but we can take steps to support this ourselves with healthy lifestyle behaviors that we found do decrease the risk of dementia years later, like aerobic exercise, not smoking, limiting alcohol use, taking heart health, making heart health. These can also help support cognitive resilience in aging. What are the warning signs to recognize that it's time for you or your family member to get your memory checked out by your healthcare provider? I like to divide it into yellow flags versus red flags. If you have 3 yellow flags, or your family member has 3 yellow flags, it is time to get checked out. The yellow flags are frequent and slowly worsening forgetfulness, repeating information, repetitive questioning, repeating the same story over again. And that's for someone that hasn't historically done that frequently. Also, a yellow flag is difficulty following conversation, trouble with daily tasks, especially those that are familiar to that person. For example, say your mother has always been the cook in the family. She's an excellent cook. She hosts all the holiday parties at her house. She makes these elaborate meals. And then you notice one holiday that she forgot an ingredient or forgot a step and is asking for help for a recipe that she's always known. That could be an indicator. Misplacing items frequently, language difficulties. This could include word finding, spelling, reading, changes in problem solving or planning, and also importantly, feedback from family, friends, and coworkers that they've noticed there's been a slow change over time with variety of aspects of thinking. Those are all yellow flags that it's time to see a healthcare provider. Let's move to the red flags. These are the major safety issues. If there's one red flag, then it is absolutely time to get in and get a memory evaluation. These include medication errors. This is a huge one. This is so common. Many older adults are taking numerous medications, maybe even in the teens, the amount of medications. These medications are taken once a day, twice a day, 3 times a day, some not every day. This is very confusing for anybody of any age, and especially if you're taking 15 medications. Now, if you or your family member notice that you're making errors and it has had detrimental impacts on your health and maybe even led to being hospitalized, that is a red flag. Then we have falls, wandering and getting lost, cooking accidents, meaning someone left the stove on and there was a fire, or a pan was burned. Impulsive and or risky behavior that is out of character. This can be very challenging, especially one certain cause of dementia, which is called behavioral variant frontotemporal dementia. Sometimes what occurs, the first signs, is that person is engaging in impulsive, risky behavior. Maybe they suddenly start gambling. They're spending down all of the money in the family. They're having extramarital affairs, saying things that are completely out of character, that are inappropriate. Now, this is a really challenging situation, especially because that type of dementia usually starts younger, maybe in someone who's in their 50s. They're still working, yet they're engaging in some of these activities, and it can be much harder to get them into a medical setting because they often don't recognize that this is problematic. Then another red flag would be potential for self-harm or harm to others, physical harm. Driving hazards is a red flag, meaning the person has gotten in a car accident. Now, of course, car accidents can happen and they're not always your fault. But if you hear the story and it seemed that there's a likelihood that it was due to cognitive impairments in the driver, then that's a red flag. So a good rule for knowing when to get a memory evaluation is if there are 3 yellow flags or 1 red flag. Now we're going to discuss what is the standard timeline these days in the US to have a cognitive or memory evaluation, diagnosis, and treatment. Number 1, recognizing the symptoms in yourself or a family member. This is very variable. This can take anywhere from 6 months to even up to 8 years. Once they're recognized, then we'll schedule the appointment with a healthcare professional. That can take 2 weeks to 2 months to get in to see them. You'll discuss concerns with the primary care provider. They'll do the history, the exam, and then they may order labs, imaging, such as a brain scan, and other tests to look for different contributors or causes for your memory loss or cognitive impairment. It can take 2 weeks to 3 months to do all those tests and get back in with your primary care provider to talk about the results. At that point, they may be able to provide a clear diagnosis and feel confident that they can treat and manage that and provide resources. Say if it is suspected that you have or your family member has Alzheimer's disease, or they may want to refer you to a specialist. A specialist would be likely a neurologist, which could be a general neurologist or a memory specialist neurologist, could be a geriatric psychiatrist or a geriatrician. This is another area that is quite variable in terms of how long it could take you to get into that visit with a specialist. From my perspective, it can take anywhere from 1 month to 18 months. The 18 months would be the specialty memory centers at academic. You get in with a specialist, then they do their evaluation. They'll send you for labs, imaging, and it can take 3 to 9 months to see you back to talk about the results, the diagnosis, and the treatment options. Putting this all together, I calculate that from recognizing the symptoms to treatment by the primary care provider can take anywhere from 1.5 months to 5 months. And then recognizing the symptoms to treatment by a specialist can take from 5 months to 2.6 years. And that's not even counting the time leading up to recognizing the symptoms for yourself or your loved one and a willingness to schedule that appointment. This is problematic for many reasons. It delays the time to getting the treatment, care, resources, and support. Furthermore, new advanced treatments in Alzheimer's disease are specifically for the early symptomatic stages. And by the time someone gets diagnosed by a specialist, which is who would prescribe those medications, that person could have advanced past that early symptomatic stage and be in the moderate stage of dementia. So they will have missed out the opportunity for that to even be a treatment option or a consideration. Part of what I really want to offer people is to understand what is the reality that we're facing in our healthcare system in the US in terms of barriers to a memory evaluation. I'm going to go through some barriers at a healthcare provider level and at an overall systems level. Firstly, there may be a lack of awareness of the advances that have happened in the field of Alzheimer's disease and related dementias in terms of diagnosis and treatment. Primary care providers have so much to do that it is completely understandable that they would not be up on all of the advances. And it is up to us in this field to provide this information in a way that's clear and helpful and empower PCPs to feel like they're going to improve the lives of their patients and families by knowing these and implementing the new treatments and diagnostic techniques. Then there's a lack of time. Visits are very short. Follow-up visits in the primary care setting are often 15 minutes. PCPs are going to address areas that are clearly abnormal, like blood pressure changes, cholesterol, diabetes, thyroid. They won't bring up the memory loss if you yourself as the patient aren't complaining about it, and that's understandable. So I'm encouraging you to bring this up if you are noticing any of these changes that we talked about. Now, another barrier is difficulty for the providers to access personalized resources and support. It's a very difficult world to navigate. And while there are lots of resources available, it is very hard. Even as a memory specialist, I find it difficult to find the best resources for that person or family that's sitting in front of me at the right time. It's very time consuming, and you want to provide them what they need and not just generic resources. So there's a lot of room for improvement in our system in that way. There's very limited reimbursement to address memory loss, to counsel on things related to memory loss. It's not reimbursed. So as a memory specialist physician, I was lucky to work in a specialty center where I did have more time, but primary care providers do not have that time. There's unclear guidelines for diagnosis and treatment of dementia and diseases causing dementia. Another barrier is that a person with the memory loss or cognitive changes, when they're earlier in the disease, will often go to their primary care visits alone, and they may not, for a variety of reasons, bring up these changes. And then finally, and I would say this one is well-intentioned, there's concern for the patient's autonomy. So the barrier to pursuing a memory evaluation is the fear that ultimately if they're diagnosed with any cause of dementia, that person will lose their autonomy. And so the provider is trying to uphold their autonomy and independence. And unfortunately, that can have detrimental effects down the road. Here are some tips to talk to your or your loved one's healthcare provider about your memory loss. Number one, know your audience. Know if your PCP is someone who feels confident and comfortable doing an evaluation and treating, or do they prefer to refer to a specialist? In this situation, you can ask that specific question. You can say it's about your spouse. Say, I have concerns that my spouse may have the beginnings or may have Alzheimer's disease. I'd like to pursue an evaluation. Is that something you would do, or would you refer me to a specialist? Next, prepare before the appointment. Keep track of examples of what has been going on over time that is concerning. Now, it can be helpful to bring this information on paper to your healthcare provider, but I would just say with the caveat that it needs to be short and sweet, bulleted to the point, no long 3-page letters, because the reality is it doesn't fit in with a typical workflow. And when the primary care provider is so busy, this may never get read. And so you want to bring information to them that they can absorb and act on. And so a 3 to 4 page letter with paragraphs, unfortunately, is not going to work. Now, I recommend being honest but respectful if you have your loved one who has the cognitive concerns. Someone who's experienced these can feel very alone and isolated and stigmatized and ashamed. People are often afraid that they're going to be told they're going crazy, they're going to be put away. I hear this from people. And so it's important that they're in the conversation, that they don't feel like you're talking about them like they're not there. The families that I've seen be most successful and do the best with these diseases have open, honest conversations. Now, when you're talking to your primary care provider, you want to use specific, clear examples about the areas of cognitive decline you're seeing. Rather than saying something like, oh, they're having trouble with their memory, say, for example, my spouse has been repeating questions over and over again, needing more reminders. I notice there's sticky notes now all over the house, and that was never a thing. They never did that before. Then you want to ask the right questions. So like I mentioned, say, can you evaluate my loved one or myself for memory loss? What tests are you going to do? What do you think this could be? And what are the next steps? Be an advocate. The squeaky wheel gets the oil. This is very true. But you want to be an advocate in a way that you're trying to speak the language of your healthcare provider. You're going to help them help you by getting to the point and knowing that they really do care about you and want to do what's best in this complex healthcare system and in this area of cognitive and brain health in older adults that there's not really clear directions and guidance, though that's improving. Then follow up after the visit. Sometimes you think orders are placed for labs or imaging, referrals, waiting to get a call, and then 2 to 4 weeks goes by and you never got a call from, say, that imaging center to schedule that brain scan. Well, I say, call them yourself and get that scheduled and take control. So that's all I have for today. I hope what you learned helps you be more informed about memory loss and aging and when and how to talk to your healthcare provider. Please stay connected. Go to our website, mybrainlove.com, and sign up for the email list. And stay tuned for our upcoming talks. These talks are meant to build upon each other, and this is foundational knowledge in dementia and Alzheimer's disease. These are things everyone should know who may be facing this. So next talk is what to expect during and after a memory evaluation. Always feel free to reach out with any questions to Dr. Cabral at mybrainlove.com.